Ladies and gentlemen, good morning. Thank you for coming today. That is Sunday morning and the last day of our conference. We really appreciate your presence. It is a big honor, a pleasure for me to introduce you today, Professor Wolfgang Fleischhacker, President of the Medical University of Innsbruck in Austria. Dr. Fleischhacker is the president of the Medical University in Innsbruck, in Austria, in which he previously served as a professor and managing director in the Department of Psychiatry, Psychotherapy, and Psychosomatics. He is a certified psychiatrist and behavioral psychotherapist, and after receiving his medical degree from the University of Innsbruck, he trained at the Department of Psychiatry and Neurology of the medical faculty there. In 1987, he was awarded a Fulbright scholarship and spent 18 months at Hillside Hospital in New York. In addition to his teaching duties, Dr. Fleischhacker also served as the Humes Visiting Professor at the Weill Medical College of Cornell University, New York, and as Distinguished Visiting Professor at the Keio University Medical School in Tokyo. In 2021, he was appointed as Clinical Professor of Psychiatry at Weill Cornell Medical College in New York. He was co-director of a Salzburg seminar of the Open Medical Institute. He was president of the Austrian Society for Psychiatry and Psychotherapy, and he was also vice president of the CINP from 2006 to 2010. He was a chairman of the European Group of Research Schizophrenia in 2006, and he was accepted as a foreign corresponding fellow of the American College of Neuropsychopharmacology. His research interest is mostly in schizophrenia and in the psychopharmacology of schizophrenia. They have led to participation in the World Health Organization and World Psychiatric Association program in the field of treatment for schizophrenia. So he's a co-author of more than 400 scientific papers, and this H-index is 70. So it will be a pleasure today to listen his talk about the psychopharmacology of schizophrenia, to learn more from his knowledge and experience. Thank you very much.
Thank you very much. Thank you, Professor Gobi, for this kind and extensive, almost exhaustive introduction. And I hope my presentation will be a little less exhaustive than this. And a warm welcome from my side as well, and thanks for showing up on an early Sunday morning in a fantastic and interesting city, which I think takes away a lot of the attention from the conference. Nevertheless, I'd be more than happy to share some of my thoughts on the pharmacological treatments across the life cycle in a sort of review process. And as you can be seeing from the first slide from my disclosures, not only have I financial disclosures, I also have some personal ones. Insofar, as all of you know, the evidence around the managing schizophrenia is not undisputed at all edges. So you have to accept, and I apologize in advance for that I will take a somewhat personal view on some of the available evidence, which is sometimes a touch ambiguous. So let me briefly start with an overview of what you will be hearing this morning. And as the title suggests, I'll run through the life cycle of the disorder, starting with the attenuated psychosis syndrome, then moving into early onset or childhood schizophrenia, then into first episode story, then the usual process that these people will have multiple episodes across your life cycles. And in the end, a topic which I think is under-researched at some point, namely schizophrenia in the elderly. So let's start out with what that life cycle looks like in a very superficial way and not totally data-based, although some of the remission numbers are sort of taken out of the outcome studies of the various life cycles stories of schizophrenia. And we'll start with the prodrome, and I'll talk about the remission rates of prodromal symptoms in a more specific fashion once I get into that section. And then after the prodrome, which usually starts in the teens, people then, if they convert to full-blown schizophrenia, are considered first episode patients, which, as you all know, has somewhat better prognosis yet at this early stage of the illness. And the remission rates here are, and that's full remission, by the way, amount to about 30%. Those who do not remit fully after first episode then have multiple episodes across their life cycles. And here, the remission criteria, depending on which set of criteria you use, are probably, again, full remission or almost full remission amount to 20%. As I said before, we know precious little about late onset schizophrenia and how the prognosis of this type of the life cycle development of schizophrenia is. And I'll run through that more specifically once we get to the end of my presentation. So let me start with the early onset of the syndrome, which is not yet full-blown schizophrenia, but which is something where some of the symptoms of schizophrenia may occur in patients at a usually not a severe and not a chronic set of symptoms yet, but evolving slowly or also remitting spontaneously. And already here you're confronted with different sets of terms and terminologies. Now all of these here mean more or less the same thing, but they have subtle differences with respect to defining either prodromal symptoms. That was basically, at least to my best knowledge, the start of defining this stage of the illness. It started in Germany in the 1950s with Gerd Huber, a mostly pathologically oriented psychiatrist, but also, which a lot of people don't know, I think the first person who ever published an imaging study. They used CT scans in the 1960s to characterize people suffering from schizophrenia. So that's the term I grew up with in my medical school and residency days. And then all the others are more modern. The attenuated psychosis syndrome, I'll go through that in more detail on the next slide. And then ultra high risk, clinical high risk, at risk mental stage, ARMS are some of the terms that are used more or less synonymously by various different research groups distributed geographically over the world. So let's start with the attenuated psychosis syndrome. And this is where some ambiguity starts. If you check the highlighted paragraphs of that, it's not a full-blown diagnosis, as you know, in DSM-5, but it's in section 3, which is accounting for interesting psychopathological phenomenon, which should be studied further, I think, is the definition of the section 3. And that includes personality disorders, but also the attenuated psychosis syndrome. Now, if you read carefully, it says here, one of the present symptoms has to be present with relatively, I'd like to highlight that, intact reality testing. Now, in my school of psychiatry, when I was taught, you either had intact or not intact reality testing, but not relatively intact reality testing. So, and I think when the people put up these criteria, they were probably also a touch ambiguous about giving a strict and clear definition for that. So that leaves open a broad range of interpretation, whether or not you believe this is relatively intact or whether this people is really not doing well with respect to testing the reality. The same holds true with the sufficiently distressing. Now, that clearly is a very subjective measure, whether something is sufficiently distressing or disabling. So just to just to familiarize you with my concerns that even this interesting and important concept is not yet really beautifully designed. Maybe future years of more definitive research on this issue will shed more light on stricter criteria here. Now, what are some of the interventions that have been tried to mostly to prevent the conversion into the full-blown syndrome of schizophrenia? Antipsychotics, various forms of psychotherapy, mostly CBT, relaxation trainings, omega-3 fatty acids, an interesting story with a great first trial that unfortunately failed to be replicated in an effort to get a more definitive answer whether that works or not. We were all pretty enthusiastic after the first study, which looked very pretty with respect to preventing conversion to psychosis. And then just general clinical monitoring was usually used as a comparison data set in this group of young patients that followed the various criteria that, as I tried to explain to you on that first slide, are considered a prodrome and a high risk for later developing schizophrenia. Now, what are some of the potential advantages of using any of these interventions that I've highlighted on the previous slides? Obviously, symptom reduction is one of the goals. But more importantly, what people at least hypothesized is that these early intervention strategies would help to prevent the outbreak of full-blown psychosis and therefore also improve the long-term prognosis and the long-term outcomes, and may prevent, and you know that there's a school of thought that believes that schizophrenia is also a neurotoxic disorder, so brain neurons degenerate in people who have especially untreated psychosis. Now that may also be prevented if you intervene early enough and prevent patients from getting really sick and fulfilling diagnostic criteria for schizophrenia. Now, at least my take on the available evidence is fairly sober. All the clinical trials that we've seen so far that were reasonably well controlled really failed to show that any of these assumptions, any of these potential advantages really work out and are really helpful in preventing the outbreak of full psychotic symptoms. So there are hints here and there, and maybe we need to move a little further towards characterization of these at-risk samples using biomarkers of various kinds, whether they're genetic or from the neuroimaging perspective or what have you, to have a more individualized approach for these preventive effects. But so far in these studies, which have mostly used the usual suspects in clinical trials, for these preventive efforts have not been extremely encouraging. Having said that, there's also a potential for harm when managing people with these prodromal symptoms early before we have an established diagnosis of a schizophrenia disorder. And I'll give you some examples for that a little later. One of them is an inappropriate treatment. Side effects, obviously, for the medications that are used are a potential risk. Stigma is a risk. Just imagine that the 14 or 15-year-old kid suddenly has to see the school psychologist regularly because he has developed some weird character traits that some people would consider an at-risk symptom. So there is a certain risk for discrimination here. And obviously it's more costly to treat someone than not to treat someone, at least in the short run. In the long run, it may be probably is extremely more costly not to treat people suffering from schizophrenia rather than just leaving them alone. So some examples from the safety side, just one actually here, and that's from one of the first trials in these ultra-high-risk patients where over a 1-year period, kids with these at-risk symptoms were treated in a random fashion with either placebo or olanzapine. And what you can see here This is the weight gain people experienced in the olanzapine group, and that's the weight gain on placebo. Just to give you one example, there are numerous others, of course, with respect to side effects. So that's one concern. Another concern, and in my eyes, that's probably the most important concern, that in follow-up studies, it had been found out that probably only a little over 20% of patients that suffer these at-risk criteria really develop full-blown schizophrenia, meaning that you would be treating 80% of these people inappropriately and unnecessarily because they will never develop the full-blown disorder. So it's a sort of overblown attempt to prevent something that may not happen in the large majority of people that experience these prodromal symptoms. So this is something I think that is a major concern here. On the other hand, something that's also been shown in these studies, about half of the patients do not develop schizophrenia, but they develop anxiety disorders or some sort of affective disorders. So it is probably fairly unspecific high-risk group for a number of psychiatric disorders and illnesses. And what you should be doing in any instance, whether or not you treat them with whatever measure you can think about, you need to monitor. These people need to be monitored a little more closely than the general population in order to make sure that none of the other non-schizophrenia disorders develops over time and gives you an opportunity to intervene as early as possible, whatever the basic assumptions for treatment may be at this stage. So moving to a fully diagnosed syndrome of schizophrenia in childhood, which is very uncommon, and adolescence, just a brief outline of some of the recommendations that are given there. Again, this is a topic where we don't have a lot of solid evidence, I'd like to stress out in the beginning. And what are some of the considerations that you should all be taking when seeing a 13-year-old with a diagnosis of schizophrenia, even though if you fully follow ICD criteria, you shouldn't even be able to diagnose schizophrenia in a 13-year-old, but that's a different story. Some of these cutoffs are really, I think, erratic, if I may say so. So what you should be doing, obviously, as always in medicine, a careful differential diagnosis is necessary here. In kids, it's especially with respect to overpowering fantasies that they sometimes experience that need to be differentiated from delusions and hallucinations. But there are other types of disorders which also make the differential diagnosis challenging. One of them could be autism spectrum disorders and various others as listed on the slide here. Very importantly, and that's a key message for people who are not so experienced in psychiatry, so the general medical or psychological or psychotherapeutic population, is that hallucinations, although they're a prominent symptom of schizophrenia, must not be the sole basis for the diagnosis of schizophrenia in children and adolescents. Substance abuse is an increasing problem also in a younger population, so that's an important distinction to make. Also, there is some overlap between the symptoms, psychopathological symptoms that occur in people abusing substances and schizophrenia, as we know from adult patients. It tends to usually start fairly slowly, and the first symptoms are more on the negative symptom side. This was the old term schizophrenia simplex, which I think correctly has been abolished from ICD and also DSM, but it sort of characterized this picture of slowly emerging symptoms that were not as profoundly psychotic as one would see at a later stage of the illness. That's also the reason why the duration of untreated psychosis is usually longer in this population, for that reason, and also for the reason that parents and also sometimes professionals tend to try to protect patients or young children or adolescents from the severe diagnosis of schizophrenia. So they would say, well, you know, this is the usual problems around puberty, and they're being difficult, and they're not doing so well in school anymore, and they don't have a social contact. They sit in their room with the black walls all day. But that's strange. They'll grow out of it sooner or later, before seriously considering that this may be a psychiatric disorder and not just a matter of pre-adolescence or post-adolescent developments. And that's something that I think is related to what I've just said. The diagnosis tends to be very stable once it's established, and there is a strong tendency towards treatment resistant, which is obviously also related to when you start treatment. So the longer the DUP, and everybody in the room, I think, is aware of that, the longer the DUP, the worse the prognosis of the long-term outcome of schizophrenia. So this just gives you a list, and I'm not sure whether it's totally up to date, and I apologize, it's very westernized because it's only the European Medical Association and the FDA that's listed here, so I don't really have a good understanding what the availability or the indications, the allowed indications are, especially in Eastern countries or countries of the global South, but it's probably going to be more or less all over the world. One of the reasons I'm showing you this slide is because you see there are a lot of blanks on it, meaning that in many countries, antipsychotics, or only a very limited number of antipsychotics, are actually licensed and registered to be used in adolescents under the age of 18 or 19. So what we're dealing with here is a lot of off-label use. So for instance, if you want to use quetiapine or olanzapine in Europe, in 16-year-old, which a full-blown diagnosis of schizophrenia, you'd be working off-label and therefore potentially putting you into legal trouble or malpractice trouble unless you fulfill the usual criteria that allow off-label management of people suffering from this type of disorder. So we're walking on thin ice when managing these people with one of the drugs that we've been very accustomed in using an adult population of schizophrenia patients. So this is something to be kept in mind. And generally, in most countries in the world, you can use off-label, but you really need to justify it. And justification usually means that you've tried something else which is on label and it hasn't worked. That, of course, can be a difficult process and takes additional time and suffering both from the patients and the relative side, and also delays the start of a potentially effective treatment. So this is a touchy issue. Another touchy issue is the transition process. By the transition process, I mean that people grow older, obviously, also when they suffer from schizophrenia, and at some point they outgrow adolescent psychiatry and move into the field of adult psychiatry. And this field of transition psychiatry, which is also relevant for other diagnoses, is especially relevant for schizophrenia because the systems don't always communicate very well with each other. And I'm not aware of a lot of centers all over the world that have a more formalized transition psychiatry program. It's mostly either child and adolescents in one house, one building, or one hospital, and adult psychiatry in another one. And not only don't they always communicate very well with each other, but they sometimes also come from different schools. The doctors who practice in adolescent and child psychiatry tend, and I'm carefully phrasing this here, tend to have a stronger impact on developmental issues or psychosocial management programs, while doctors in adult psychiatry, again saying this very cautiously and with a grain of salt, tend to be more on the biological side, tend towards the biological side of treatment. So there's a sort of communication gap that may develop from this. And I don't think I need to convince you that obviously the integrative part of psychiatry is what's key here and what's relevant here. And at this point, let me bring a little caveat into perspective. Obviously, this is a psychopharmacology conference, so I do not talk a lot about psychotherapy or sociotherapy, only to mention that, of course, I consider it a key relevant feature that must be applied next to the classical psychopharmacological measures that we're focusing on here more in the context of this meeting here. So we have few specialized services here, and the communication between child psychiatrists and adult psychiatrists, I think there's room for improvement here. So this is a certain challenge that we need to keep in mind when moving people from one field or one subdiscipline of psychiatry to another one. So let me, by the way, this is Innsbruck, huh? And the surrounding mountains, so it's quite different from what you experience here. It's very pretty, and I'm not sponsored by the Austrian Tourism Agency when showing slides like these. First episode, schizophrenia. We could all debate for hours when dealing with the fact how to best manage first episode schizophrenia. So I'll just pick out a few points and some very selective references and data with respect to this issue here. Why is it so necessary to intervene as early as possible? Duration untreated psychosis, I've already mentioned the relevance of that. I've mentioned the neurotoxicity. What I've not mentioned so far is what I've termed sociotoxicity. What do I mean by that? By that I mean that obviously these people are visibly and clearly ill, and which makes them a potential, which puts them potentially at risk for a lot of stigma and discrimination, and also they're in school, they will have difficulties. They'll have difficulties in their workplaces being recognized as unusual and strange and weird, and therefore there's a risk to exclude them out of the usual societal responsibilities that we all share in communicating amongst each other. And I think that this is a critical issue that should be avoided as much as possible. And the other thing that is extremely necessary for the long-run treatment of the disorder is to establish a sound clinician-patient relationship here. This is key to all management and diagnosis in medicine, but especially so in psychiatry, and in psychiatry, especially so for people suffering from schizophrenia, for the simple reason that of all the psychiatric disorders that we manage, schizophrenia is the one that has the least probability of patients having insight into their illness. So you need to make sure that you have an empathic relationship with them, that they understand what you are able to offer, and that you understand what they want to seek from your help. And these issues may be very different at certain times. So this relationship, I think, is something that is an important prerequisite for a relevant and successful management of people suffering from schizophrenia. Just one example with respect to choice of drug, because that's also been an ongoing discussion. This is a study that we did in Europe and Israel quite some years ago, and where we tried to find out whether the new generation antipsychotics do any better than the classic antipsychotic haloperidol in a long-term study in first episode schizophrenia patients. And what you can see here is that all the new generation drugs, so that was amisulpride, olanzapine, quetiapine, and ziprasidone, clearly outperformed haloperidol with respect to all-cause discontinuation. Now that's a very broad criterion, but I think for schizophrenia it's a highly relevant criterion, because irrespective of, for whatever reason, a patient stops medication, it generally, not always, but generally is not good for this patient with respect to the long-term outcome of schizophrenia. So that's why we choose that very broad and clinically based criterion, because it's so relevant. And this study has now been replicated a number of times, and there's ongoing discussion, but I think the field now really agrees that your first choice, if possible, should be a new generation antipsychotic. And there's probably no preference to which of the new generation antipsychotics you should use, but that takes me back to the doctor-patient relationship, where you have to make sure that the patient, and sometimes also the patient's relatives, accept your suggestion with respect to treatment. And that may sometimes be based on very irrational principles. I once remember a patient that I managed who was doing extremely well on a specific antipsychotics, and he stopped taking it, even though he was basically healthy. He stopped taking it after 2 months or so. And when we discussed why he stopped taking it, he said, "I don't like the color of the box. It makes me feel nauseous." This is crazy and totally irrational. But if people don't like the color of something, they're not going to probably continue doing that. So just to give you one example of the choice of ways to choose medications that may not be totally obvious from the outset. So in the long run, I think most people are doing pretty well with any of the new generation antipsychotics. So what are some of the specific considerations that you need to keep in mind? One of them I've already mentioned, which is doctor-patient relationship, which has a major impact, of course, on adherence. And whichever term you prefer, whether it's adherence or compliance, this is a key obstacle in managing schizophrenia over the longer term, as most of you will understand and probably have experienced yourselves. And schizophrenia patients just don't do very well with respect to continuing to take medications. But I should also mention psychiatrists do not do very well in convincing patients that it's important to take medications over decades and sometimes in a lifelong fashion. Most doctors would experience, if you have a high blood pressure, that you need to continue on your antihypertensive basically forever. Same is true for statins if you have elevated lipid levels and this and that. But psychiatrists in many instances are still reluctant to really recommend long-term treatment, and that's especially true in schizophrenia patients. So adherence is something that you need to manage very early on when establishing the relationship with your patient. DUP, I've talked about. The therapeutic relationship is of course key to anything, but you also need to know that although generally first episode patients respond better than more chronically people to antipsychotic drugs, they also have a somewhat higher risk to develop all kinds of adverse events that you need to manage over the course of time. And there's also another truism: use a dose as low as possible. Although I must admit, I've always had some problems and difficulties with understanding the minimal effective dose range. Because if you think about it closely, the minimal effective dose range you can only really establish after you have established the maximum inefficient dose range. And therefore, it's a sort of a loose concept that I'm not very convinced one should be following. So what we usually do is we start at the lower end of the dose range that has scientific evidence that it really works. But we don't try to go below that just to potentially avoid the risk of adverse events. You can, of course, do that by giving very low doses. Patients will have a lesser degree of side effects. On the other hand, also this lower dose range may not be as effective as the one where we have scientific proof. So just to give you my doubts on the concept of the minimal effective dose. So let me move on to chronic relapsing schizophrenia, so the patients that do not fully recover after first episode and never experience a second one. And again, there are lots of considerations here. With respect to management, and This slide I'm showing you because it's beautiful. It's from one of these network meta-analysis which allows you to compare drugs in a mathematical fashion that have never been compared in real life. Very sophisticated and nice to look at. Just to give you a few outlines here, the thicker the lines are, the thicker the lines are, the more studies there are available in this example, comparing oral risperidone to long-acting risperidone. And the larger the circles or the balls are, the more patients have been included in these clinical trials. So it's nice to look at, but doesn't really help you in making a clinical decision. On the other hand, from the same study, there is sufficient proof here that, and that's, I think, one of the most undisputed findings and one of the best documented findings in psychiatry, that antipsychotic treatments prevent the relapse in patients suffering from schizophrenia in a very effective fashion. Not in everybody, not with every drug, but almost every drug that's been ever studied in a placebo-controlled trial has shown a better outcome, better edge, whatever measure you look at, whether it's relapse rates or whether it's symptom improvement or quality of life improvement or what have you, than placebo. So that's really something that should be deeply ingrained in our thoughts, and we should also try to convey that to our colleagues and obviously also to patients and their significant others. This is one of the best documented research findings in psychiatry. By the way, it's also one of the best documented research efforts in general medicine. If you compare effect sizes of all kinds of medications that you can think of in general medicine, and this finding, you will be seeing that psychiatry is actually doing very well. By the way, that also holds true for the long-term management of bipolar disorder and other studies. So we're right in the ballpark of internal medicine here, of oncology or what have you. And that's also something that needs to be considered, that you should never downplay the effectiveness of the medications that we're using in the management of people suffering from psychiatric disorders in general, but more specifically schizophrenia here. Now, one of the ongoing discussions is depot antipsychotics. You know that we have now available for quite a number of the oral antipsychotics. We have depot versions, and the injection intervals range between 2 weeks and 3 months, or even 6 months. And in many clinicians' eyes, this is a very helpful story. Other people are more worried about potential risks incurred in people using depot antipsychotics. And again, the patient side and the relative side has to be taken into consideration here as well. Now, this is a somewhat confusing story, and historically, these are the first 3 meta-analyses that I've seen on this topic. First, Clive Adams in Oxford found that on the top here, that depots were not any better than oral medication in treatment discontinuation. Then Stefan Leucht, who's done a lot of the meta-analyses here, Stefan Leucht found that there is an advantage of depots over oral drugs with respect to total relapse rate. A few years later, the same group, then spearheaded by Taishei Kishimoto, found that this vanishes after adding 2 or 3 extra studies into the equation. So as a clinician, you weren't really sure what message to take from this. And this meta-analysis story continues. This is the most recent one, at least the most recent one that I've seen, that combines a number of different methodological approaches to studying the differences between depot and orals. And again, here, same group with a few extra authors finds, yes, now suddenly we do have an advantage of the LIAs against their oral counterparts. So as I said before, this is not always a clear and obvious story here. And one of the reasons why the findings have been so inconsistent, I think, lie in the methodology of this study. Classic randomized controlled clinical trials, blinded, sometimes placebo-controlled, may introduce a certain bias here, and probably the largest bit of bias lies in the fact that patients in clinical trials generally get more extensive, and I'm not saying care, not to be unfair, but at least more and extensive attention than people in regular treatment settings. And that is especially relevant in the management of long-acting antipsychotics insofar as, quite frankly, the people that get more attention also generally have higher compliance and higher adherence rates, meaning that they will take also their oral medication regularly, irrespective of the mode of application, and therefore the difference between oral drugs and long-acting antipsychotics will vanish, because it really doesn't make a difference pharmacologically whether someone takes an oral medication regularly or whether you introduce a long-acting antipsychotic. The big difference really is, obviously, whether or not patients take the oral medications, and if they do, they will do as well on the drugs as if they were on a long-acting antipsychotic. Now, this is clearly in my eyes, one of the reasons why sometimes cleverly and well-designed comparison studies of oral and long-acting medications do not show differences between the two application routes. So a certain bias paradoxically introduced through good and sound methodological designs. One of the examples that my American colleagues always used was, if a patient doesn't show up for an appointment in our regular outpatient settings, we may give him a call once or twice or call the relatives. And if we're unsuccessful, he just doesn't show up, and there's a mark in the record, patient hasn't shown up. If a patient in a clinical trial does not show up for an appointment, we will send a black limousine to his home to pick him up because he's so important to keep the trial alive, just to give you a practical example of these issues here. So there is a selection in these studies. Of course, part of the selection is also the consent forms. People who have to sign consent forms of 15 pages are generally a little more, have a little more insight than patients who have no insight at all and say, well, what do you want to do with all this paperwork? I'm really not interested after having read the first paragraph. So you may pre-select a certain group of patients that does do better, would also do better in a routine clinical setting. Two studies that have attempted to overcome these methodological concerns are on the next two slides. One is the PRELAPSE study, Prevention of Relapse in Schizophrenia, done by John Kane and his colleagues in the US. And they compared 20 centers each. One of the centers used the long-acting version of aripiprazole, and the other center used the oral version of, used treatment as usual. So whatever treatment the doctors chose there. And they found that in the centers that used a long-acting drug, the first hospitalization occurred much later than in patients that used the routine treatment. So they argued that this was an important sign that people generally tend to do better on a long-acting drug with respect to early rehospitalization. Again, this was open treatment, and only the centers were randomized, but not the treatments were randomized. And we did a similar study in Europe and Israel. And unfortunately, as things happen, our results were not as convincing as the results from the US group. We also used an open design, but we randomized people to either two depots, one of them being paliperidone, the other one being aripiprazole, or two orals, again, aripiprazole and paliperidone, and followed them up for 1.5 years. And our primary outcome measure, again, was all-cause discontinuation. And as you can see from this graph, there really wasn't any visible difference, whatever drug or whatever mode of application, I should say, patients were randomized on. So it leaves us here that we're still sort of furtively looking for the truth, but maybe continuing research with a little more sophisticated and more individualized characterization of patients may be helpful in informing us which route of application to choose in further studies. Now, I've listed here, and again, this is my own experience, sort of embedded in the available evidence, some of the potential advantages and disadvantages of using depots. And let me start with the ones that are clearly not true. Depots do not have less side effects, as some people have argued, but depots also do not have more side effects, as other people have argued. In my experience, and also in the read of the literature, the truth, if there is a truth, is highlighted in red. A, obviously, LAIs are more expensive, which is a problem, especially in low-income countries. And B, they do have a low acceptance rate. And importantly, they don't only have a low acceptance rate in patients, but they also have a low acceptance rate in clinicians, in prescribers. Stefan Harris in Munich did an interesting study years ago where he asked doctors why they would not consider prescribing depots, and the doctors would argue, well, my patients don't like them. And then they went back and did something very tricky. They asked the same patients, and the same patients actually, a large amount of them told her, you know, I've never been told about depot medication, and I've never had the chance to even consider that option. So just there's a certain ambiguity on our side here as well, especially in the process of trying to demedicalize psychiatry very much. This, I think, is an issue and a problem that we need to consider when relating our ideas towards acceptance of these drugs. The one thing that for me is a compelling argument is not that they improve compliance, which I don't think has ever been shown, but they ease the monitoring of compliance, because it's very easy to know that a patient is not compliant if he doesn't show up for his injection appointment. Whilst on the other hand, it's never easy to judge compliance correctly if people are on oral medications, even though everybody tells you, of course, she or he has taken his meds regularly, and the patient will also try to convince you of that. Probably the only reason you can find whether or not that happens is doing a plasma level, and even that is not perfect as a measure here. So compliance monitoring, and therefore also potentially dealing with compliance issues is much easier if a patient is on a depot. And the other psychological advantage, I think, it basically eliminates these discussions and these questions about compliance or adherence. You know, you ask your patients the obvious questions. Do you take your drugs regularly? I'm not sure if any of you ever has heard a no to that answer to this question. Even if you come up with trickier question, a more sophisticated question, say, what happens if you don't take your medications? Do you experiencing anything different? After the second time you've answered that, you've asked the question, the patients know exactly what you're up to when asking this. So this topic of compliance is sort of taken out of the equation of patient-doctor communication, which I think is very helpful. And if it's brought up by the patient when they say, you know what, I don't think I want these injections anymore, and then you can move on and do all kinds of compliance-enhancing measures that you're interested in. So these, for me, are the relevant features when considering a depot antipsychotic. So just to briefly summarize that part, what are the considerations? And I think I don't need to read this slide to you, but more or less covers what I've tried to convince you in the previous slide here. So let me move to two specific topics, but extremely briefly. Two topics that are much more challenging than relapse prevention or the management of acute episode, irrespective of the life cycle that patients are in. One is negative symptoms. And negative symptoms, especially so-called primary negative symptoms, namely those that are an inherent part of the illness of schizophrenia, are a pharmacological challenge. We don't have a lot of good evidence. There's some indications for amisulpride, some older studies, but these were small-scale placebo-controlled trials that didn't have an antipsychotic comparator in them, seemed to indicate that there would be an advantage of these medications in people suffering from persistent negative symptoms of schizophrenia. But apart from that, we really don't have a lot of tools. I should say we really didn't have a lot of promising tools, and a number of new studies a number of new molecules have now come up, which have at least provided us with some hope that this may be different in the future. And one of these drugs is cariprazine, which is a powerful D3 partial agonist or D3 antagonist, whichever pharmacological school you belong to, and has shown in this one study and also in a couple others that were not as well controlled as this one, advantage over risperidone in a comparative blinded trial that lasted over half a year. And not only was there a psychopathological advantage with regard to negative symptoms as measured with the factor of the PANSS score here by the end of the observation period, but also, and I think this is highly relevant and important, there was also an advantage with respect to psychosocial integration. So the PSP, the psychosocial performance scale, showed about a 10-point increase, which the authors of that scale consider clinically relevant over the same observation period. So on one hand, you had an improvement in psychopathology. On the second hand, you had an improvement with respect to psychosocial integration. And I think these need to go hand in hand, because if we only improve psychopathology, I think that's la pour la and doesn't really help the patient in his real life. Just to give you one example, and there are a number of other compounds that are currently under investigation, one of them being pimavanserin, which is a different mechanism of action and is licensed for treating psychosis in people suffering from Parkinson's disease, where there are ongoing phase 3 studies after a fairly successful phase 2 study. And raloperidone, which is a sigma antagonist, has also been, at least in one study, seemed to indicate that it does well against negative symptoms. But again, the jury's still out on that drug. So far, I think cariprazine is the most convincing. Cognition is an extremely difficult and challenging topic, and it's one of the key features of this disorder. Also, if you remember the history, dementia precox was not based on hallucinations or delusions, but on the cognitive impairment of people suffering from schizophrenia. And I'll leave it to one slide here, which may look a little pessimistic, but I think it fairly covers the current evidence on whether or not any medication helps improve the cognitive function of people suffering from schizophrenia. You may remember that when second-generation antipsychotics were introduced, there was a big hype around the fact that these drugs may also improve cognitive dysfunctions. Close inspection of that hypothesis never really held true, and if at all people did better, it was A, practice effects, or B, just the fact that some of the new generation antipsychotics have lesser side effects. So people who have less tremor or are not akinetic will also do better on neuropsych tests, obviously, because they're usually paper and pencil or on computer screens, so they just do better. So I think this is an indirect improvement, depending on the fact that we have less side effects, and therefore the cognitive science measures that we employ show better results. There are a number of interesting compounds, various mechanisms of action, ranging from glycine reuptake inhibitors to approaches approaches tackling nicotininergic or muscarininergic system, which in phase 2 trials and also in preclinical studies show encouraging results, but we still await a really well-designed phase 3 study that convinces us that this approach, the alternative approach to anything that tackles the dopamine system, is something that we will use in the not too distant future to augment the cognitive function of people suffering from schizophrenia. So I'm now moving towards the end of my talk. And very briefly, let me speak about, I'm away from this clock here, but I still have a green light. Late life schizophrenia, as I said at very outset, under-researched, very difficult, very little evidence available to this point. It's uncommon, the onset after 65. There are other causes of psychotic symptoms in the elderly, which I think we need to focus on. Dose and safety of antipsychotics, of course, as in the very young population, is important, as these people are generally more vulnerable also towards safety problems. And they do reasonably well, but not fully remit generally, but most of the symptoms can be held under control. How common is it? It's not very common, so the prevalence rates relate to the overall risk for schizophrenia, and it's after 60, even lower prevalence rates. And interestingly, there's a higher risk for males in younger patients. In older patients, there's a higher risk for female people. Probably has to do with the hormonal changes in menopause. Some hints with respect to the differential diagnosis. And let me just highlight a few here. Cognitive impairment is much more stable and progressive in dementia, which of course is an obvious cause of cognitive impairment in the elderly, whilst in schizophrenia, they're there already very early on, and after a certain degree of stability, there's little progression that goes on here. The quality of the hallucination tends to be different, and also the delusions. People with dementive processes tend to have more real-life-oriented delusions. Their hallucinations are much more often acoustic hallucinations, while in schizophrenia we have more optical hallucinations and more bizarre and illogical content of delusions. So these are just some of the issues here. Obviously, dementia is a progressing disease, while schizophrenia at this age, in this part of the life cycle, tends to be a little more stable. So just to give you a glimpse here on the differential diagnosis, some pharmacokinetic measures here are relevant, and just to give you, hepatic metabolite goes down, therefore the plasma levels will go up of the antipsychotics you use. Therefore carefully choose the dose. You have a higher risk for interaction, because usually these people on a number of different drugs, not only psychotropic agents, and protein binding goes down also, which argues for higher plasma levels. So that's something you need to take into account. So quite generally, slow dose start and increase slowly, as we generally do in other instances as well. Interactions, and at the bottom we have, as I said before, we don't have a lot of evidence, but for the 3 medications listed here, we at least have trials in the elderly, sub-analysis of large-scale clinical trials, which would argue that these are okay and safe to use and effective also in a post-65 generation of patients suffering from schizophrenia. So, in review, 2 slides. Taking the argument that, or turning the argument that these drugs are helpful in the long-term management of schizophrenia around, Don Goff and others argued that we have basically no evidence that we do a lot of harm when we manage these people with antipsychotics over the long term, and that there is powerful evidence, there's powerful science to support the fact that this is a helpful measure, that this is a helpful measure. And the main principles of diagnosing and managing schizophrenia apply to all parts of the life cycle. Yes, yet there may be subtle differences here or there that I've tried to convince you to take into account when managing people suffering from this disorder. So thank you very much for listening, and if there's time, Professor
Thank you very much. We have only 58 seconds.
Okay.
Maybe. Just...
Well, congratulations, Wolfgang, for providing us with this such great overview of the field, and as well in a very clinically important manner. My question is, how much effort is there for using LAIs, especially with our partial D2 agonist in first episode psychosis? Is there really a lot of pushback against that, knowing that some regulatory agencies would even accept to use, approve the use of clozapine in this early population?
Yeah. So with respect to LAIs, I think the same thing applies that I've told you for a chronically ill schizophrenia population, but the reluctance from clinicians is even larger in first episode patients. A lot of the clinicians say, oh, you know, this is a first episode and the prognosis of the disorder is not so bad, and so let's wait and see what happens. And a lot of them tend to wait for at least a second relapse, which may, or not actually a first relapse, I'm sorry, which may not really be a good idea. On the other hand, you could take the route of suggesting an LAI even to a first episode patient based on the data that we have, and then monitor this patient closely and reconsider maybe after a year or so, or after 2, whether or not this patient may belong to the prognostically more positive group of the ones that are in full remission after a certain period and will not have a relapse. So it's more difficult even than to convince doctors to prescribe LAIs in first episodes. But it's generally the doctors and not always the patient's side. We always blame the patients. We shouldn't be doing that.
Thank you. We have to finish here this conference. Thank you very much. If somebody has questions, can come here and ask directly to the professor. Thank you very much. Bye.
Thank you.